And we're back. All right, we're back. This is Senate Health and Welfare, and it's still April 2nd. We are looking at H13, and we have Monica Ogilvy from AHS, Medicaid Director. Welcome. And do you two want to be up together? Alicia Cooper.
If that's all right.
Yeah, terrific.
Great.
Good. Thank you for being here.
Thank you for having us.
And so I think you know everybody. Probably.
Yeah.
Okay.
Nice to be you again. For the record, my name is Monica Ogilvy. I'm the State Medicaid Director from the Agency of Human Services.
And I'm Alicia Cooper. I'm the Director of Managed Care Operations for the Department of Vermont Health Access.
Go right ahead.
We are here mostly to be a resource for you, answer questions, and see how it can be in service through this legislation. Generally speaking, we're in support. This is something that we already do, that we have done, and we're happy to continue doing it in a more transparent and clear way, both for our providers and for the legislature. So that's our overall position. And then if there are technical questions about our capacity to do this and timing and cadence of how we've done this in the past and how we anticipate we'll be able to continue doing this for these services, that's really Alicia's area of expertise. So I wanted to make sure she was here and available to you as well.
Okay, thank you. Questions committee. When we go back, as we hear from folks, and you're in the room, if you hear some things that are concerned, it will be helpful to have your feedback on that. Any questions? Cost to the agency to put this in place?
We, like I said, we already do this. I think we have capacity as it stands to do roughly 3 studies per year. And so if we maintain the same cadence, then we should be able to do that within our existing resources. If there was a desire to do more studies or at a more rapid pace, that's where we would likely need additional resources than what we have now.
All right, thank you. And we did hear from joint fiscal that there was no fiscal current on this. Okay. Committee, any questions? I'll let you go. Oh, you're still here in the room, and that's okay. Okay, good. Thank you. All right.
Madam Chair, there is a fiscal note.
There's just no fiscal impact. Yeah, that was a mistake, right? So Molly Dugan is here. Thank you.
Good morning. For the record, my name is Molly Dugan. I work at Cathedral Square, and I was going to share my screen, so I was just going to do a quick PowerPoint. Right. There it goes. Oh, perfect. Okay. Sorry, that took a minute. Okay. So again, I'm Molly Dugan, and I wanted to my testimony will be brief. We're very much strongly in support of H13. I did want to take a moment to share a little context about the organization where I work and why this bill and this system of information that it sets up for us and for you all is so important, because we are a provider of long-term care services. So we're a lot of things, and that's what this slide tells you. So Cathedral Square is almost 50 years old. We are a developer of affordable housing. We have soon to be 28 affordable housing communities, primarily in the northwest section of Vermont. Our newest one will be opening this summer in the St. Albans area, right downtown. Affordable senior housing. We provide property management in all of our housing. We're a licensed long-term care provider. We have 2 assisted living facilities that I'll talk a little bit more about. We provide technical assistance to other housing organizations like ours when they're working primarily in older adult housing. That's really our niche. That's really what we have specialized over these many years. I try to be an information resource for policymakers and you all. And we're very importantly, we are the statewide administrator for the support services at home model SASH, which has been around now almost 15 years. And this just gives you a sense of the different properties that we have in the northwest corner of the state. As I said, we have 27, soon to be 28. These are primarily housing for older adults, subsidized, they're affordable, and they all have the SASH services embedded. And we thank you all very much for all your support for UHCB and for SASH through the years. So I want to focus on our assisted living because it is these communities that are so aligned with this particular bill. So we operate 2 assisted living communities that are licensed to the state. One is in our flagship building, which is in downtown Burlington, Cathedral Square Assisted Living. And then we have a memory care assisted living community in Williston. The chair has been there and toured that with us a couple of years ago. So it's a really, really special spot. A couple of quick facts about these 2 assisted living communities. The Cathedral Square Assisted Living, the one downtown, is 30 apartments. Importantly for this conversation, we could have more than 30 assisted living apartments there, but we had to take some offline back in 2021 due to the workforce shortage we're still in workforce shortage, but it's not as bad as it was then. And we were lucky because we have that high rise has a bunch of floors of independent senior housing. So we could flip those ones we had to take offline to assisted living and just fill them with independent living folks. But is it the right thing to do demographically and knowing what the need is for assisted living? Absolutely not. It pained us to take those beds offline. When we could, we actually had permission to go up to 40 assisted living apartments in there, and we can't because of the cost, because of the workforce shortage, et cetera. We have 20 of the residents that live there are qualified for nursing home level of care reimbursement. That's what enhanced residential care is, ERC. And we have one resident that is getting just the basic level of care, which is through the assisted community care services. So you'll hear about ERC and ACCS. Those are the payment types that go along with the level of care that's needed. So my point here is that most of the people we care for in both our assisted living facilities are nursing home level of care. They're with us. It's less costly. They're in community. It's an option for them rather than nursing home. We have 302 people on the wait list for those 30 assisted living apartments. So it takes about 3 to 5 years. The memory care at Allenbrook, the one in Williston, it used to be the Vermont Respite Home before they moved to Colchester, and then we bought it. It's 14 apartments. Again, high percentage nursing home level of care. So we're keeping them in community at a lower cost community. We have 118 people on that wait list, 3 to 5 year. Importantly, 100% of the residents at memory care at Allenbrook rely on Medicaid to pay for their care. Almost 90% of our Cathedral Square assisted living, the ones in downtown, rely on Medicaid. Yes, thank you.
Connie and I have had a lot of conversations in finance related to Wake Robin, which I know is a very different model, but when you look at the assisted living at Cathedral Square, is that a situation where folks might come in as, independent living and then move into that nursing home level of care? Is that how that works typically, or?
So it's,
Across the
so you're
floor.
absolutely right, that it's not set up like Wake Robin in that it's not that if you come into Caddo Square, you don't have to make an investment initially and then that allows you, that guarantees you, you can go to assisted living if you see it. This is not set up like that. So we serve primarily low income people. What we do provide to our residents who are in the independent apartments, they have priority for assisted living if there's a spot that's open.
Less than this.
Yeah, but there's no, we can't guarantee that, oh yeah, you'll go right. You know, we have almost 1,200 independent senior housing residents, so there's no way we could guarantee that. We wish we could. So our residents at these assisted living communities are low income. They rely on Medicaid, and memory care in Allenbrook, we have Section 8 project-based housing there, so it is truly affordable. I mean, this is really the only one in the state that couples Section 8 affordable housing with the Medicaid. So you have to be very low income to get there,
And that is a 24/7 care.
24/7.
Yeah, correct. Yeah. Not necessarily in, like, are they on the same floor? I'm sorry, I'm trying to, I need to visit, obviously. I live in
Yes,
Burlington. I
love
need
to
to
have
go.
you. Yes.
I've been to the ones out on
In New
North
York,
End, yeah.
yeah. So these are different, but they are apartments.
Yeah.
And you know, that is typical for Caddo Square with our assisted
Yeah.
living. At Memory Care at Allenbrook, it's all one floor. At Caddo Square, it's 2 floors of assisted living. And there's a dining room, shared dining, activities. Yeah. Okay, so then I just want to get to age 13. We fully support age 13. I also want to mention that Caddo Square is a member of the Long-Term Care Crisis Coalition. There's a number of other representatives here behind me as well, fully in support of age 13 for really these same reasons. You know, we need higher rates of Medicaid reimbursement to provide the care that's needed for our residents. Age 13 does not have an appropriation, doesn't require that you know, these rates go up, but it provides that system, that infrastructure of information, so that you know, well-informed decisions and can be weighed and thought about. So that's what's important to us. We need predictability of payment. Our costs increase every year, and we need to be able to budget accordingly. You know, some of the data for us, you know, we have these 2 assisted living communities. Our resident assistance rates, those are the personal care attendants, since from 2019 to 2024, those rates, payment rates, wage rates have gone up 28%, which is good. They should be paid more. We've always thought that. So that's great. We got them up there, but that's a huge increase to be able to absorb when you can't be guaranteed you're going to get reimbursement rates that increase on a regular basis. Our nursing rates, so because our assisted living have nurses as well, gone up 42% between 2019 and 2024. Again, we need these qualified staff. We want them to be paid like they're being paid and even more. But when we rely on Medicaid as our primary funding source to pay for the care, there's only so much you can do. The deeper rate study that was put out in February 2023 is obviously already out of date. So we're concerned about us losing traction again. We need, obviously I shared the wait list information. We need more Medicaid beds for Vermonters. You know, we're seeing closures over time in both residential care and assisted living. And yet the demographic that's growing fastest in this state is 65 to 74. And that's just going to keep going up. So this is not what we want to have happening. And we need the entire continuum of long-term care options in our communities. And that's really what the Long-Term Care Crisis Coalition represents, is all those community-based long-term care providers. And we're the one, you know, we are very cost effective. We're saving money right now when we're able to keep people as close to their home as possible. So age 13 really, we believe, provides that system of predictability and information that's needed. That's what I got.
That's good.
And anyone else that wants a tour of our properties, you can come back, Chair.
I know.
You can provide the tour for her.
Yeah. It's really worthwhile visiting, really. And it's also worthwhile visiting Cathedral Square downtown or South Burlington, wherever, you can access.
Thank you. Where those hundreds of folks who are on waiting lists, I mean, where are they? They're in their own homes? Are some of them houseless and in motels? I mean,
So about, great question, about 20% of our residents that live at Cathedral Square properties, about 20% were formerly homeless. So we absolutely house formerly homeless. And we absolutely do in our assisted living communities as well. Where are they if they're not with us? Those that are waiting 3 to 5 years for assisted living. Many of them are living at homes and you know, in their own homes and relying on you know, as much care as they can get from family members from the system that exists, but they know that their needs have gotten to a place where they want to come into a 24/7 community that's close to their home and that, you know, gives their family members that might be in the workforce the ability to actually be 100% part of the workforce. I mean, every friend that I have is dealing with aging parents and having to miss work and having to take leaves of absences. So this is nothing new. We need to bolster this community long-term care system.
Other questions? Okay, thank you. Great. So I've got Amy Johnson and then Jill Helm. Yes, great. And we may have some questions for AHS. Good morning.
Just have to get a PowerPoint going, so.
Okay. Did you bring a friend?
I did bring a friend, I brought the president. Not the president. but-
thank you.
Good thing.
Our Vermont Care Partners resident. Okay. For the record, Amy Johnson, Vermont Care Partners, and let Kelsey go.
And I'm Kelsey Steps, the executive director at Northeast Human Services and the co-president of Care.
We can't hear you. My suggestion is to turn your video off and try again. It's choppy. Choppy, good word. Go ahead, maybe introduce yourself again, please. Are you
Hopefully you
there?
can hear me this time. My name is Kelsey. Can you hear me?
Yes.
Sorry, I may try and call in. The one. I'm not great here.
So we're having real difficulty with the audio coming through. I'm wondering, Amy, can you give the testimony?
Oh, yeah.
It was nice to say hello and meet. Your president. Okay.
Well, Kelsey can pop on, that's fine.
Okay.
This is brief. We're fully in support of H13, just gonna do a little bit of level setting, a couple of recommendations. Hopefully Kelsey's able to pop on, but if not, that's okay. Hopefully I can make the slides. So I just want to start with, there's some language that already exists that pretty closely mirrors H13. I know that there's some people in this room who helped to work on this piece of legislation. And you know, it talks about the secretary setting the rates, you know, being mindful of mandates, whether federal or state, often unfunded, which we see a lot of, and then inflationary increases. So this is in statute, however, we often, when we're getting inflationary increases or rate increases, that happens at the legislative level. And so we support H13 in that we will know the true cost of care. And ideally, it's something where we're not all having to come here year after year asking for something that we all know that we need. And I'll get more into that. So I want to talk about kind of where, like, the state of the state financially, like where we're at and why this bill matters to us. And so this is looking at consumer price index, going back to fiscal year 28. This is as far back as we could go with our financial folks. So it makes the assumption that we were in a good place in fiscal year 2008, although I've been told that we weren't. But you can kind of see in that first column, that was what CPI is, our inflationary appropriations for DMH and Dale, and then that third column is the variance. And then Department of Substance Use, because many of us are preferred providers, we have that in there as well. And so I'm not going to go into great detail. I'm not CFO, but this pretty clearly shows you that CPI year to year, the rates don't keep up, and it just demonstrates how far behind we are at this point. So there's a pretty large gap that I think we need to be mindful of, and I know that the legislature is. But when we're thinking about this bill, and we're thinking about those inflationary increases, we're really far behind. I mean, you can see that, 11.47% variance for DMH and Dale. So we're struggling, and we see the impacts of that through staffing and through wait lists and through folks not getting what they need. This isn't a budget presentation, but so I'll refrain from that. But
Thank you for putting the key in there.
yeah, I added that recently because some of the acronyms. So just to show you some of our non-staffing budgetary pressures, when we talk about like what's happening year after year and why it's important to adjust the rates and understand the true cost of care. This committee knows really well health insurance costs are through the roof. And so even when we get rate increases, trying to keep the lights on and trying to retain staff, we're trying to offset that health insurance cost. So it's not hitting them in their paychecks. If we're not adjusting for that, then they might be making a bit more money, but more of their paycheck is going to health insurance. And then we have a lot of other operation and other fringe that overhead to keep the lights on, and that goes up year after year. So when we don't get the increases, there's a pretty big impact, and we see staff leaving, shuttering of programs. So this, I'm not going to go into detail about this. I can talk about this if we come back for a budget presentation, which I saw emails from Kiki, so maybe.
No fair,
But just to show you kind of where we're at, we typically sit at 6,000 staff positions, and right now 5,200 of them are filled. So we have a lot of vacancies, and there's a pretty obvious reason for that. When people leave, the number one reason they leave is wage. And I think the tricky thing is it's really hard to get people in the door when they say, well, do I get an annual increase? And you say, well, it depends, right? So, but the rate increases do matter. And this is the more important slide to show you that when we do have increases, we see vacancy and turnover shift. The extent to which it shifts depends on the increase that we get. Often you work really hard to get increases. Often it's not what we need, but it does help. So I just wanted to point this out, that the rate increases do matter and have an impact on our ability to keep staff and have those relationships with clients intact and good quality of care, and also bring new people in that we need, since we have a lot of vacancies. So that is to say, we support H13, and I don't know if Kelsey's able to pop on, or he still sounds like a robot. If he does, that's okay. But it's really important for us to address the inadequate base rates. You're going to hear the same thing in this room from all the providers, that we just what we're getting paid is not the true cost of care. We need to, be mindful of inflation.
Amy,
What-
can you hear me now?
Yes,
Better.
yes.
Okay, good. So,
So-
yeah.
Go ahead.
Amy.
You want to add?
Well, I just want to add, there are a couple things. One, just want to, thank the legislature for the increases we've got over the last 3 years. It's made a big difference across the network. I think we saw the vacancies coming down. And I think that's a direct correlation to those increases. I can speak for NKHS. Over the last 3 years, we've gone from 445 employees to 530. I think that speaks to the need. And also, we were able to pay higher wages. We do a culture and climate survey every single year and track it year over year, longitudinal data. And there's a number of things that we're always working on, including culture. But the number one reason people say they'd be more likely to stay, or we actually ask it in the negative too, what's the number one reason you leave your job? It's always pay and benefits. And so I do think we provide pretty robust benefits, time off, health insurance, and that's one of the biggest drivers of the cost. So having the ability to understand what an appropriate raise would be based on just CPI, that's for cost of living, and not related to doing more services. So that's about keeping the lights on and carrying on with the acute work that we do. And just, I know everybody is well aware of what the designated agency, a specialized service agency, but our main referral sources are primary care, the hospital, probation and parole, Brattleboro Retreat. And so, we really perceive ourselves as the safety net. That's an affordable option for Vermonters in our communities, and really see us as essential to the continuum of care that we provide, but also to keep people in their community in less intensive and less costly services and locations. And so being able to count on a regular increase allows us to stabilize some of the most pressing issues in our community. And, I just want to say, we work really closely with the state, and there are so many great ideas, and we're evolving. And I know Vermont can be seen as innovative and changing. And, we invest in planning, we invest in thinking through what best practices and adopt that. And we also need investments in the doing. And the people who are doing the work are doing really hard work, some of the most acute work in our communities. They're supporting law enforcement, they're supporting emergency rooms, usually to keep people out of the wrong place of care. And so investing in the people who are doing the work on the ground is essential to having good outcomes and putting those tax dollars to use.
Thank you. That's helpful. Good.
So the only thing I would add, this is kind of showing like where we support. There's not a lot of recommendations. Obviously, we would love to see this bill have a auto inflator in it. It would be, again, investing in the people. It's great to know the true cost of care. That's really important. And then to be able to get that funding to be able to keep the services going. Similar to state workers, we're very supportive of the increases they get, and we think that there should be parity with that, as we're the ones providing the services required by the state.
That's been an ongoing concern.
Yeah, I was gonna say, as long as I've been coming here, but I know you've all been here for a little bit longer than that. So, and we want to make sure that when we're doing the rate study, whatever the methodology is, make sure that we get it right, that providers are involved, kind of nothing about us without us. And then there is a section 2 part B that talks about considering geographical differences. I understand, from an equity perspective, I think that's important. I just want to make sure it's more of a question. Just how do we ensure that we don't undercut agencies who are already way under what they need? So that equity piece is really important. But if you're thinking that somebody's already, has been underfunded chronically since the inception of the program, we want to make sure that we're not giving agencies less when there's so much that they need right now. So just wanted to point that out, to be mindful
Well, it could
of
be
that.
more if it's a transportation issue.
Yeah,
So
exactly.
that consideration could,
Yeah, either way, just that's what I was thinking about from like the first slide that I showed with the CPI, of how below we are already, where we're coming from and where we're trying to get to. So that we're in support, and more information if you need it, we're available. I mean, I'm here every day. So, that's it.
That's good. Thank you.
And the last thing, thank you for bringing up transportation. I just want to note in the, rural most communities, which the Northeast Kingdom is one of those, we book over 2 million miles last year to get people. And that's going to important appointments. That's getting out in the community and fulfilling our, duty of care. And then the other point I would make is, sometimes I think about this in the system space and saying an underinvestment in Medicaid dollars still squeaks out in other ways. And I would say adds to the pressure on private insurance and third-party payers. And so we're seeing that in the increases and have to pay that out and saying, an investment in the Medicaid rates and the designated specialized service agency should help offset pressures where people are utilizing services that aren't necessarily necessary, but needed because we've been historically underfunded.
Thank you. Great. Thank you both. Very helpful. So Jill Mazza Olson is here. Welcome here.
Thank you.
The DNAs.
DNAs. Good morning. I'm Jill Mazza Olson. I'm the Executive Director of the DNAs of Vermont. So we represent home health and hospice agencies. I've seen you here before this session. So we also support this bill, both as home health and hospice, but also as a member of the Long-Term Care Crisis Coalition. I think this is really important. And, to me, as I look at this bill, we've done a lot of work actually on both the home health side and on the long-term care side with DVHA to try to at least get a handle on how our rates compare the cost on long-term care and how they compare to Medicare for our skilled services. And it's been really important. I think it's important that legislators understand where we are stacked up against our costs and stacked up against Medicare. You make hard choices every year and down the hall in the budget, but when you make hard choices that don't include us, we make hard choices. And we're going to see more and more of that. Regardless of what happens at the federal level, we're already on the wrong track. So I think it's really important that when you start to see agencies not able to provide services, which is already happening, there's a lot of home-based long-term care that's just not happening because there are no people to do the work and there isn't enough dollars to fund the service. I think it's important for me to be able to say to you, we needed a 50% rate increase, you gave us 15. That's what happened. That is what happened. And so I think it makes it a lot more clear why we're in the situation that we're in. Most of the providers who are in this rate study, probably all of them, are dependent on government payers. So home health and hospice agencies get paid by Medicare. So we're lucky that way. In terms of the funding, it's usually somewhat better than Medicaid. And we're funded by Medicaid. We have very little commercial insurance. There's nowhere else for us to go when we don't get rates. We used to be able to supplement underfunding in Medicaid with overfunding essentially in Medicare. Those days are just over. So it's obviously not an appropriation bill, but just to jump on this shaper and bandwagon, we did do a recent survey of our members just to see how they're doing on operating losses. So in their last fiscal year, some of this is audited data, some of it isn't. So the system is running at a 10% loss, operating loss. And I have one member who's as much as 25% on their operating margin. And that's an improvement from the 35% the year before. So serious losses. And this is how we got to a closed agency a year ago. So anyway, this is not a bill that would require an appropriation, but it is a bill that will at least make sure we all have information coming in, especially when we're way behind. It's really hard in this building when we're way behind to catch up because everyone's well, we'll give you an inflationary increase, which is not better than no increase. But when the rate is behind, as some of these are,
Doesn't catch up.
we're never going to catch up at that pace. And so I think this has been really important
And just to mention on our skilled services, so when I say skilled, I mean medical care at home, nurses and therapists in your home, usually after a hospitalization. Really important care. Those services have a Medicare equivalent, and so that's what we worked with DEVA on all summer. There was actually some language in the budget about this to compare those rates to Medicare because there is an equivalent. And you've heard me say it in this room, but I'll say it again now. We're at about 67% of Medicare. Our Medicaid rate is at about 67% of Medicare. So you have actually made really good progress for us over the last few years in moving that rate up. We were sort of focused on a lower fee schedule for a while. We got to that lower fee schedule, which was great, which is why we asked to then create a methodology to compare to full Medicare. So that's where we're at. So it's been really helpful work. It's helpful for me to see, it's helpful for members, and I think it's just really important for legislators to understand what you're asking us to do. And what we're working with in terms of resources. So,
Always.
yeah, always depressing. Jump out the whole thing. Always depressing. Okay, that'll be my new tagline.
You think of anyone that's optimistic in this.
No.
The topic.
I know.
Senator Gulick.
It is depressing, and I don't want to be a downer, but where I sit, it seems as though a relatively poor, small rural state like Vermont, when we don't get the support that we need from the federal government, we are being told to let people die. And that is what our government, the people in power right now in Washington, are saying to us, let people die.
Well said. You don't even have ice walls anymore. So I'm going to bring a topic up after we've heard the testimony that I'm going to ask you all to help me out with for a minute, but any questions for Joe? Thank you.
Thank you.
As usual, inspiring.
I must be in the wrong room.
No, to keep from crying.
Yeah.
We're getting overloaded.
Are there too many? I'll step out. I have two guests that I think might find this interesting.
I won't say anything interesting, I promise you.
Or depression. Yeah.
No, I represent the nursing homes, it's not.
Oh.
Okay, so my name is Helen Laban. I'm Executive Director of Vermont Healthcare Association. We represent assisted living residences, residential care homes, and nursing homes in Vermont. So surprise, we support H13, much like everybody else in the room. We are also part of the Long-Term Care Crisis Coalition. I'm mostly here to be available to answer questions and to just continue to add some of the context and emphasize points that some of those speaking before me have made. So within our membership, this bill is looking at the assisted living and residential care. It's not about the nursing homes, which already, they're sort of on the other end of the spectrum of how complicated one can get in doing rate studies. And so they already have a system that's in place with elaborate reporting and review. That sort of system is not what we're talking about here. I think that Jill, Director Ogilvie, put it very well in summarizing that what we're really talking about here is a data-driven check-in on a regular basis about where we are with rates versus costs for these key services. For my members, as Molly mentioned, that would be assisted community care services and enhanced residential care, so ACCS and ERC rates. We are experiencing increased costs, as everyone did. As Jill mentioned, it's not as simple as an inflationary increase from year to year, partially because we're behind, but also because these costs aren't necessarily moving in a linear fashion. They are service-based, and we're also regulated entities. So we're licensed providers, and we do have occasional changes to the services required to be provided or what the requirements are for offering residential care home and assisted living. So there are both an ongoing increase and occasional changes to what you need to be able to provide to maintain that license and serve residents who are using Medicaid as their primary payer. Medicaid is our primary public payer within this system. We do not have the equivalent of Medicare services in this particular type of residential long-term care service. And we rely on the state to continue to look at those costs, and bring our rates up accordingly year to year. And we would simply like some database information to have that conversation with you all every year as you look at the budget. That's really the basic goal of this.
Thank you. Questions? No, thank you. That was very concise. Appreciate it. They're all been very good. Sort of. Seriously, I do have an ask of you, and it's not something we're going to discuss now, because I think Senator Douglas also wants to bring something up, but was it an executive order that just canceled the long-term age planning for Medicare at the federal level? It came out last night. It's awful just to read the news, but that just happened. We're going to be potentially, we don't know. We just don't know where the federal government is landing with Medicare or Medicaid or anything. However, the intent is there to really hurt. So my question of you is, how do we look at the emergency funding? What do we do? I mean, as an agency, I know you're looking at this. Just looking for other folks in the room to consider what is the emergency response plan for all of the loss that we're going to see in your particular area. And is there something that we can do? And understanding that we are under, we have federal guidelines and rules that we have to follow, but when we don't get federal dollars, we don't have to follow. So what are the state rules and guidelines that would help fill the gaps? And would it save money for us to be under the state rules and guidelines rather than what we currently have? I mean, big question there, but so where's the money come from, and how do we put it out there, deliver it to services for folks? Currently, there are contracts with our DAs and our SSAs. I'm looking at go with this, but we already have those contracts, and some of those contracts have provisions based on federal guidelines. And what happens when those go? Does it really enhance our ability to provide services? So I'm asking for that, and it's not something that can come back tomorrow. It's not something that come back next week. It's something that we all are going to have to evaluate and consider. But we need to do something. I think we are doing something, and many of us, but just trying to include all of you in the thought process and what can happen. So that's it. That's my ask. Not related to the bill necessarily, although you brought it up. All brought it up, the needs that we have, and we're going to see more needs very soon. There it is. We can't put people on the streets out of Cathedral Square or our nursing homes or anywhere else. They need the support. So anyway, any questions, for anybody? Yeah, I know that you have Sam's going to bring us. Senator Douglas has got an issue for us.
Do you want any response to your question there, or do you
Sure.
want? Okay.
Give me a response.
So
Do you have a full list of what we can do? No,
I have options galore.
I know.
None of them are good. They're going to be great. So I think, from the Medicaid program perspective, what we're doing right now is, on a daily basis, sometimes more times than once a day, having to plan for all of the policies that we're seeing that could potentially come down from the federal government. Everything from rescinding our 1115 waiver to establishing work requirements to, a per capita cap, either for the entirety of our program or changing the way the formulation happens within our waiver. I mean, sort of the options feel a bit endless right now. And so we're trying to take a breath and take this information and distill it into what it would mean for Vermont and not panic at this moment in time because we
No,
don't
we
actually know
can't.
it. We don't actually
You're
know
right.
what happened, right?
Can't-
But we are trying to work through what all of those scenarios might mean. Part of the exercise that we're doing, and I love the way you characterize this, Helen, as really this is like a data-informed decision-making process that should be transparent, that we should have access to. And recognizing that we might not have money to increase all the rates as the studies and
Right.
Studies and evaluations show. But we are looking at the Medicaid program. We are seeing what's defined as core. We are seeing what we are doing that is outside of core and that we have flexibility to do or not do based on federal mandates. And if we were to shift some of that, would we need legislative action? Would it be, what would the levers be that would actually allow us to make a change versus not make a change? What would the fiscal impact be? What would the human impact be? We've heard the governor say he wants to fund people over things. I think, can't remember the other word, but people is what I remember, and that's what I was about it. So happy to hear that. So we are trying to create a degree of cover to say, okay, is there any bit of this crisis that we want to use? Like to your point, if we're not beholden to the federal government, does that give us any flexibility that maybe we hadn't contemplated in the earlier stages of this? So we are doing that inventory now. We have provided some testimony already, and happy to come and provide some testimony about where we are in terms of understanding the implications and where we actually do have flexibility to change services or, but as you know, our levers are population, rates, services, and Medicaid admin. We already run a really lean Medicaid admin program. And those other levers are all, scary for their own reasons. So, but we're happy to lay out all that information as we continue to announce.
So we'll get to that. I think that would be helpful for this committee. I know that's going to happen in the appropriations committees and others, but it would be helpful at some point when you think it's a good time to do that. That'd be great. Thank you. Thanks for that. Appreciate it. And thanks for your work on it. So, Senator Douglas had a suggestion for H13, coming back to the place where we are. We'll just spend a couple minutes on that.
Yeah, so my suggestion for an amendment wouldn't affect the bill at all as it stands, just adding an addition. So my bill on the wall that we have here, S99, is a study for welfare cliffs. The benefits cliff is a big issue. It's been a big issue for a very long time. Obviously we weren't able to address it for crossover, and I think it would be germane enough to be able to add on as an amendment to this. And of course, it doesn't affect anything in it as it stands, just tacking it on to the end or wherever generally think it's appropriate.
The question is to AHS that maybe you could take home for us. Looking at S99, what's involved there in terms of capacity at the agency to do that study, if it were added on to this bill. That's really the question.
Yeah, and I'll also note that with your testimony on your own leader capacity of being able to do studies, changing the effect, or sorry, not the effective date, but changing the due date on the report as it's currently in the bill, it's perfectly fine with me. If it, right now it's on or before November 1st, I think 2025, which I thought was short to begin with, but changing that to 2026 would be perfectly fine with me. So you have a lot longer to go that.
So that's a question.
Yeah.
We've got it. So let us know what your thoughts.
May I ask a clarifying question?
Yeah.
So am I interpreting the bill correctly in that you want to understand where those eligibility cliffs are, where if someone's income is X amount of dollars, they no longer receive a public benefit?
Yeah, that's the problem. So if I can give you a little of history on it. So
that'd be so helpful.
Yeah, so I went to Joint Fiscal and I was asking all these questions. Senator Beck and I were working on this together, trying to figure out some solutions for the cliff. Nolan, well, I was hoping he'd stick around a little longer for this conversation, but, he said, yeah, give me a month. It's the beginning of the session, give me a month. After 2 months, he came back to me and said, this was way bigger than I anticipated. Our entire office kind of got in on this, and there are so many rabbit holes that we found on this topic. We're just not able to do this and get you the information you're looking for. And he recommended asking AHS for a study. So this was his recommendation, and the language is kind of a combination of mine, Senator Beck's, and then Nolan's language kind of combined together. So this is something Joint Fiscal is asking for, and obviously Senator Beck and I are asking for, so we can collectively, I think something that this committee are probably very interested in coming years is trying to address that problem. Obviously, people shouldn't be losing 100% of the benefits they have for trying to work extra hours in their day job. You know, we want people to work.
Yeah, if you're trying to get at that perverse disincentive of
Work, yeah.
once you increase your income, then you lose benefits. But there's a gap that's created in that, a chasm really.
Yes.
There.
So
Yeah.
the language in S99 is what programs currently exist, who implements them, where is the funding from, what ones can we touch? You know, obviously the ones with federal funding, we can't address that. And there's a lot of uncertainty as you so cheerfully reminded us.
Yeah.
So that's
Yeah, we could certainly take that back and consider it, especially where we would actually have authority to contemplate changing those. But obviously there would be probably a significant fiscal impact if you were to change some of those one way or the other.
Yep.
So,
So I guess the question here is, does the agency have capacity to accomplish what's in the bill? Not necessarily change any rates, but to do the study itself. And because I know how busy you are, but we also would be great to be able to see the results of that work.
yeah, sure. I can take that back to the agency. I think that some of that is actually quite in line with what we're doing in terms of assessing the federal policies. That's all about. It's all about changing those splits.
Yeah. Also, it's a page and a half, and a lot of that.
Oh, yeah, for a little bill.
It is for a little stuff.
Yeah, I'd be happy to follow up. Thanks for the additional context. That was really helpful.
Good, that's helpful, because, and then what we're gonna do with this bill is we're gonna move forward pretty quickly on it. So we'll go through it with Ledge Council again. I think we might find some time this week to look at it, and then we'll do markup and on it early in the week next week.
If I may, can I make one additional comment? Just
Yes.
recognizing that our substance use disorder providers aren't in the room and this does have an impact on them. Because they're listed in H13.
Who would we like to bring in for them?
Oh, well, I think you heard from Chad. I heard from Chad.
Oh, got it.
I think that they would be in favor.
Yeah.
But in that vein, I can see some similarity in some of the other legislation that's been introduced in S36 and H13.
Yep.
So just ensuring that we create some alignment there, just for us logistically would help in the management. Because
Help us with that, because we
Yeah.
don't want to do anything that takes you out.
Exactly. No, thank you.
Yeah, disjointed. No, we're understood. Okay. But that's our timeline, just, you know, you can send something in and to Kiki and copy.
We can.
Okay, anything else, committee? Senator Cummings had to go to a money chairs meeting, so that was why she left. All right, so we are adjourned.